Hello, everyone. This is Dr. Cross. I'm just going to do a uh, fairly brief video on week one review, which will discuss introduction and background of the course. Course overview, as you know, this is psychopathology. We will be talking a lot about different mental health disorders in this course. But we also start off the course on giving you a general introduction on psychology and its development over time, meaning past and present conceptualizations of mental health issues. We will also be going over DSM-5 diagnosis, which is very important in your career in social work. Whether you decide to do direct practice or CAP, understanding mental health disorders will always be helpful to you because you never know whether it be in your personal or professional life that it will call for you to understand what's going on with somebody. And being familiar with certain diagnoses as well as the list of symptoms associated with those diagnoses will help. So this course will introduce you to some of the common disorders such as schizophrenia, bipolar, depressive disorder, anxiety, obsessive compulsive, just to name a few. We will be covering those in this course, and you'll be more familiar with those disorders once you're complete with this course. But it's not just understanding the disorders themselves, it's also understanding how to utilize the DSM 5 and how to find your disorders, how to link symptoms that are being presented or observed by a client or a patient, and then assessing and diagnosing a disorder based on those lists of symptoms. You also want to understand what are some of the socio-cultural, political factors related to um, disorders. They just don't always occur out of a vacuum. And they're not all genetically based either. Sometimes there are specific social, cultural, political factors that um, increase the risk of certain disorders or definitely contribute to the development of a disorder. Also, you need to understand, and you'll learn this in the course and this week particularly, what does mental health or psychopathology look across the lifespan? I already uploaded a video this week that talks about the course assignments for this course and reviewing the syllabus, which did constitute your course overview. But now I want to have a discussion related to specifically what do we mean when we talk about psychopathology. You will hear me use psychopathology, mental health disorders, or disorders interchangeably in this course, but we are definitely talking about a mental health disturbance, usually one that can be identified through the DSM-5. But before we understand what's going on, we usually first are aware that something is going on with somebody from a mental health or a psychopathology standpoint because there's some type of abnormality going on. This week's discussion board, week one's discussion board was about abnormality. But how do we understand there's something abnormal going on? What constitutes abnormality, and what leads us to heading toward the DSM-5 to find a diagnosis? Um, our readings in abnormal psychology talks about deviance as being a key feature. When we're talking about a deviance, we're talking about things that are wrong or something that goes against what we know to be the norms. And it's usually negative. So when we're talking about abnormality, we are thinking about what is considered norm. Norm can be very vague, and it's really dependent on culture, race, as stated, social, cultural, and political factors all influence what we consider as a society as a norm. What may be normal in the United States may not be normal in other countries. So we have to understand what is normal, what is considered normal behavior. But we also need to make sure that we put that normal behavior in the proper context because what we may think of as the observer as being abnormal, once you consider the social, cultural, political, sometimes religious factors that are involved, it's quite normal, but we perceive it as being abnormal. So one way to consider it again is understanding what the norms are and also understanding what a particular norm may be in a culture. Um, that is how we determine what an abnormality is. But we're not just limited to norms and what is society's norm, what is a cultural norm, religious, racial, ethnic. You give me a descriptive, the norm can be fit specifically within that. But we just are not relegated to that. We also consider other things such as distress and dysfunction. That is less observed by a clinical social worker, and that's more reported by the client and or the family. So another way we decide whether something is abnormal is understanding the level of stress involved in that abnormality. And we're trying to measure or determine how much and if that client or patient that we're working with is under distress and what is the nature of distress. So again, we're looking at things like norms based on society, cultural, social, political factors, but we're also trying to gauge how much distress that client is under, how much dysfunction is related to that distress or dysfunction related to whatever the problem is going on, and if there's any immediate danger to that client. That danger can be environmental danger, such as a risk of losing a job, a risk of self-harm, self-inflicted harm on the. It could be that they're in a social situation that is a real risk of threat, such as intimate partner violence and or domestic violence. So another criteria that we consider when we're thinking about abnormality are things like distress, dysfunction, and specifically any danger. Danger will always be a key feature for clinical social workers or any type of mental health professional, because once we find out that there's some kind of danger or high levels of risk involved, we want to be able to measure and document that, because the whole goal of mental health is wellness, but also more importantly, safety. And so, usually, whenever a client may discuss any issues of danger or concern about safety, we want to now pull out even more clinical tools to make sure that that client is safe enough or is not at imminent risk. And again, that could be suicide, that could be a domestic violence situation, because we need to make sure that patient is safe. And that is the epitome of what we're doing here. Wellness is the goal, but safety is paramount. Similar to safety, we also want to measure how much dysfunction and distress is going on. Some terms that you might want to think about when you're thinking about dysfunction and distress is mild, moderate, or severe. And not only just having a gauge from your clinical lens on how you're considering it, but more so how you're either using screens to rate it, Likert scales to understand it better, and more importantly, making sure that you document based on client report. This week's reading also talks about some of the historical view of treatments for clients. It is important that you do the readings with related to the historical treatments, because in your assignments, your written assignments for the course, you are expected to discuss the historical trends. Another note I want to mention while I'm talking is that originally the chapter for this week was listed as chapter 6 on Blackboard, but it's actually chapter 1. If you read chapter 6, that's okay, because it will be covered in another section later on in the coming weeks. But we're talking about chapter 1 in Comer and Comer Abnormal Psychology. I also uploaded a video too that would help you with the discussion board question as well. But the whole goal, in terms of historical, the section of the historical past and present treatment, is that we've come a long way with mental health treatment. How we view mental health changes with each version of the DSM-5. The DSM-5 is our gold standard book that we go to measure, to categorize and measure abnormality. So as I stated earlier, the DSM-5 has went through different versions of it, which shows you how our changes and how we view disorders as well as the symptoms have changed over time. But again, as history changes, as we learn more as clinicians, as we study and understand the brain more, our conceptualization of mental health and disorders have changed as well. And you can see that through the changes in the DSM-5 over time. And you can also see it through our study of the historical changes in treatment over time. Um, as I stated earlier, some of the things that we look at is whether something is normal, whether there's cultural implications to that normalcy, whether there's political, religious, spiritual, ethnic, and racial implications to that normality or abnormality. But once we realize that there's something there that's not quite right, at that point, we may be able to um, observe or document a list of symptoms and or behaviors in which now we have enough information to consult the DSM-5. One of the biggest critiques about the DSM-5 is that it's only as good as the version you're using. And what I mean by that is, again, because we learn more about the human brain, the human body through medical technology, we're able to know more now than we did before. And as we learn more, our assessments look different, our treatments look different, and our interventions will look different as well. Also, something key to understand is that as we change our understanding, we improve our ability, but then that's also a critique because there were people who are already assessed and diagnosed and treatment plans already corrected before we knew what we knew. And so that is definitely a critique, and it is very limited. Sometimes the DSM-5 can be used to label people, and we consider that negative. The whole point of the diagnosis is not to label the person or turn the person into the diagnosis. It's to set us down a path in which to develop an intervention that will really work for that particular client. And that aspect, that is a critique of the DSM-5 as well. It is used to limit clients based on a disorder or create a client from the disorder rather than utilizing the group of symptoms to understand the client better and to help that client better. There are cultural critiques based on who was involved. It's not necessarily that applicable to all diverse cultures, religions, even. It limits what we consider abnormality, and it always doesn't take into consideration those cultural differences. And so we may give somebody a disorder based on a list of symptoms that may be very normal in a specific culture, or in a specific religion or in a certain race. And then we're pathologizing, if you will, things that may actually be normal, and that's another critique. In your readings, you'll learn more about the critiques of the DSM-5, but they're definitely there. This is not to say that we don't use the DSM-5. It's the best we have at this time. We utilize it, understanding that there are limitations, but we don't allow those limitations limit our client or limit our ability to work with clients. Um, there are also some social, cultural, and political factors to consider. One reading that I did not include, but you may want to take a look at it to learn more about socio, cultural, political factors, is your synopsis of psychiatry textbook, chapter 3. This book, in general, there's a lot of readings for this chapter, and so I left it out, but I did want you to be able to know where to go to read more about social, cultural, political factors. There are a lot of readings for this course, and very hard. You want to put everything in so the students understand, but then you want to be mindful of how much you're overwhelming them with the readings. So I did not include that um, in this week's reading, and it may be in a subsequent week, but just take a look at it since we're covering social, cultural, political factors this week. But just to illustrate some examples to you, I would like to let you know that a lot of times when you're thinking about mental health disorders, that be it depression, that being anxiety, that being stress-related disorders such as acute stress or PTSD, sometimes these disorders are not biological or genetic in nature. Sometimes they are environmental factors such as social, cultural, political, and religious factors that impact somebody's mental health. When you think about social, cultural, think social factors, think about somebody's home environment, if there's inter-partner violence. Maybe it's a child who is in foster care that may impact, those are the type of factors that may impact somebody's mental health, particularly related to PTSD, particularly related to attachment issues, particularly related to trauma. And again, We want to understand the social makeup of a client and what's going on in their social systems. And if there are what we like to call abnormalities in that system, even though it may be normal for that client because that's their life, those are abnormal social situations that can impact somebody's mental health. Some of the cultural type of factors that may impact somebody's mental health may be related to cultural customs, expectations that may impact somebody's mental health, or the combination of cultures. Perhaps a Muslim woman chooses to marry a non-Muslim man, and that can cause a cultural conflicts within the family, and that may be problematic. There may be some cultural customs related to marriage and arranged marriages that can potentially provide distress to a particular client. But understanding what those cultural factors are and how they're impacting the mental health of the client is key, and it's very important. Examples of political factors that might impact somebody's mental health has to do with sometimes the political climate. Particularly under this current administration, there's been a lot of changes in the political climate. And I must admit that in the US climate, which is heavily influenced by political factors, have turned at best um, hostile toward minorities and people of color. Um, in response, there have been political movements and pushbacks, such as Black Lives Matter. But we can't assume that these things don't cause stress and trauma in certain minority groups. There have actually been political orders made related to immigration that has separated families, removed children from their parents as well as their families. Um, that will cause impact on people's mental health. These are abnormal factors. These are abnormal things that are happening in our social, cultural, and political world, and again, even religious. And all these things will impact somebody's mental health. Along with the DSM-5, in which we use to understand and categorize a set of symptoms that we may be seeing playing out in a client's life, whether it be internal processes related to genetic and genes, or abnormalities in the brain structures, or the social, cultural, and political factors. We still have tools in which to better understand what is going on. Again, one being the DSM-5, but we also use things such as the mental status examination to again understand how well that client is particularly functioning in a given circumstance. We use this again through self-report, but we also use the information that we gather from clients, and then we apply the DSM-5 and other assessment tools, not just the DSM-5, but also the mental status exam. As stated in earlier videos, we have a mental status exam um, listed as part of our case study guide. So when you're approaching your assignments for the course, you want to start off with what are the abnormality. When you do your case study and case analysis, I want you to be very clear on what are the abnormalities that you're experiencing or observing, and what makes it an abnormality. Now, I really want you to really think hard about what makes what you're seeing abnormal. One, what are the observable behaviors, self-report, distress, dysfunction, any cultural, social, political, religious factors that may be contributing to those or to the observed abnormalities. And that's how you start. Once you're pretty clear and observable, documented is the key. Can't add symptoms, can't make them up. They have to be there. It has to be documented and clearly identified in your case study information. Once you do that, now you are on the road to potentially having a strong, firm, and accurate DSM-5 diagnosis. And that mental status exam helps you with that diagnosis as well. So think about those type of abnormalities Also, when you think about the diagnosis as well as the observed behaviors, abnormal behaviors, think about how you feel those type of behaviors were treated historically as well as presently, and think about some of the current evidence-based treatment for those disorders, and that's important as well. Also, as part of your case study and case analysis, I want you to think about, and in some cases discuss, what your DSM-5 diagnosis is and link that to the observable and or the reported behavior or symptoms in the case study. But also think about some of the symptoms that were not listed, which would have helped you make a stronger diagnosis. Perhaps maybe from your DSM-5 review, 3 or 4 out of 7 diagnosis symptoms were not met. And you can talk about that in your critique. I believe this person has this disorder because 3 or 4 of the symptoms were met. However, in order to make a stronger diagnosis, these other 4 need to be met. And that would make it a more accurate diagnosis. Um, I like case studies, particularly because it really teaches you to use your clinical skills to identify a disorder or a list of symptoms and behaviors to come up with a disorder. And those are the clinical skills that we're trying to grow in this course or cultivate in this course. The other reason why I like the case studies is because they provide you with some information. It doesn't provide you with all the information necessary to provide the type of diagnosis or 100% certain diagnosis that you want to make. And that is okay because that is how patients present. We're using weekly, bi-weekly, once a month sessions with our clients to continue to gather information so that we can continue to either confirm our original diagnosis, refine that diagnosis, or improve upon it. As you get more information from the client, you may change your diagnosis, and that's fine. You can only make a diagnosis with the information that you have at that time. So don't feel frustrated because you don't have enough information from a case study or in your cases from the field to make a strong diagnosis. That is real world. That is what happens. But what we're looking for, particularly in this course, is I'm trying to grow those skills and be able to um, get you to a point where you can make a firm diagnosis based on the evidence that you've had. So what you're doing here is justifying a diagnosis based on the behaviors and symptoms that you are seeing. And you're aligning them directly and succinctly to a DSM-5 disorder. In our your readings for this week go into further detail about case studies and as well as give you some limits to the use of case studies. Um, your readings also go over what some of the research um, looks like and some of the research methods and designs in abnormal psychology as well. Also, the readings cover abnormality models or models of abnormality. We talked about disorders being genetically, um, clients having mental health issues or disorders that can be linked to genetics. We also know um, that some disorders that are more biological in nature has to do with genetic predispositions, ones that tend to have more correlation with uh, brain structure or brain function. They tend to respond better with psychopharm or what we call psychopharmacological medication and biological treatments, psychotropic medications to help improve outcomes for clients. We also know that some disorders that tend to be more influenced by environmental factors, social, political, cultural, economic factors are tend to be more environmentally triggered, so respond best by improving those stressors or dysfunctions in the environment. And so oftentimes understanding the root cause, the factors that are involved, helps you as a clinician find the right treatment model that will work. And sometimes it's a combination of addressing issues in the environment as well as a combination of psychotropic medication. You also learn about some psychodynamic theory, such as the psychodynamic model this week and how it's used, as well as some of the treatment methods used, such as electroconvulsive therapy and psychosurgery. Some of them are more historical type of procedures that are not as commonly used. But again, when you're thinking about how you're treating a client, understanding what is going on with them, whether again it's from a genetic or an environment or a biological source, it helps us determine how are we looking at the client and what is explaining the problem. We use clinical theories to help describe what is going on in terms of the relation of the environmental stresses, the dysfunction, related to the disorder, related to the behavior. So when you think about what's going on with your client, why it's going on, and how your client is suffering mentally from it, you want to align that that piece, those pieces of the puzzle to a theory. And what we mean by that is what theory best explains what is going on here. And so this week's reading starts to talk about some of it, and one of them definitely is the psychodynamic model. It also talks use some of the concepts from psychodynamic model in terms of the defenses such as repression, denial, projection, rationalization, regression, displacement, and intellectualization. Those are all theoretical concepts that we use to help us understand what is going on with the client. Some of your assignments for this course require you to describe what is going on either in your case study and or case analysis with your client through use of theory. Also, it's important to understand what are some of the psychodynamic therapies used. Again, your assignments in your case study and case analysis require you to discuss some of the historic as well as present day treatment therapies. And so some of the readings this week cover some of those models. Again, psychoanalytic therapy was identified, so psychodynamic theories were identified. Also, concepts such as free association, resistance, and transference was also covered. These are concepts that we use when we're having conceptualizations or talking about client information and understanding our clients amongst therapists. Another very strong and evidence-based therapy, that was discussed is the cognitive behavioral model, which is a theory as well as a therapy. The readings also cover learning theory and some behavioral approaches that you may also want to think about when you're talking about your case analysis and case studies. More importantly, behavioral concepts such as modeling, classic as well as operant conditioning. All those things are those tools are very important, and we use them in understanding of theory as well as therapy and treatment options um, for client for clients specifically. Our readings also talk about some of the assessment ways that we assess cognitive behavioral models in clients. Also, some key therapy tools that are very useful and some that are holistic as well, such as the mindfulness model and mindfulness treatment approaches, which is very useful for um, patients that do not need a psychopharmacology treatment or patients who are resistant or have adverse reaction to psychopharmacology or medication. A holistic treatment such as meditation and mindfulness tend to work best for them. Um, and some clients who are on medication still try to utilize some type of meditation or mindfulness models to improve their symptoms over time. Be sure to make sure that you read the chapters in detail. Do not skim them because they cover some of the major theorists and theoretical models, such as the humanistic existential model, And you may want to utilize any of these given theories in the readings to understand your client or explain what's going on best with your client. Um, the multicultural perspective and the family social or sociocultural model is also listed in your readings. And again, you might want to think about using that, as well as some of the popular behavioral models and treatment models, such as group therapy, um, family therapy. Again, whatever you think may be best given your client issues and those factors that we talked about that may be impacting the client's mental health. Um, the readings also talk about some other type of models depending on the type of client you have. For instance, if you have a married couple and or two partners, you may want to think about utilizing couples therapy as your mode, particularly if the symptoms and the behavioral problems are grounded in the dynamics between the couple or abnormality in terms of behaviors in the couple within the couple's unit. Again, the book, the readings cover multicultural treatments as well as sociocultural models. Please be sure to read them in detail and consider if those are good models that you want to use to address um, the issues that you identified in your case study and or your case analysis. Other readings that you will need to consult is your Handbook of African American Health. This week's readings cover some very important um, frameworks, theoretical frameworks or models or paradigms that you can use also to discuss your client. By the bioecological model was discussed in those readings. And that's important because you might want to think about discussing your client from an ecological framework. And it also identifies its use in working with particularly African American clients related to health disparities. Um, I think thinking about physical health and mental health is important. One, because people of color and minorities are at high risk of health disparities. We like to think that mental health is different from physical health, but they're on the same spectrum. We oftentimes stigmatize mental health where we don't stigmatize physical health. However, if you give me a person or a client that has a physical health condition, particularly a chronic health condition, it's very common for them to have an accompanying mental health issue. Think about someone who's battling cancer. Think of somebody who's a diabetic. Think of somebody who may have to have their um, limb amputated because of diabetes. Think of somebody who's bedridden because of chronic illness. Think of somebody who's constantly sick every day. It's not that hard to understand how somebody with a physical illness can turn into a mental health condition, it be it anxiety related to pain, fear, medical personnel, fear of death, worry, PTSD, depression. All these things come hand in hand with a physical health condition. However, the opposite is true as well. You give me somebody with a mental health condition, it can turn into a physical ailment. Why? People with depression oftentimes commit suicide. Not all the time, but they are at increased risk for suicide. Somebody who has anxiety issues, high levels of stress can take its toll on their immune system and they can become sick. People who have severe mental health issues can either put on tremendous amount of weight because of appetite disturbance or lose a tremendous amount of weight because of appetite disturbance. I can give you more example. However, we treat them differently, but they're more closely linked than we think. So much so that we know that sometimes people with mental health disorder actually need fight psychopharmacology. They need medication to help them feel better, just as if they were to have a chronic health condition. Again, in our society, we tend to stigmatize people who have mental health issues, but we don't stigmatize. It makes sense when somebody has a physical concern, but it does not make sense when they have a mental health concern. And hopefully as clinical social workers, we can change that narrative and stop treating them any differently because they're more linked than they're not. But as stated, the week's reading also talks about how we can use behavioral interventions, how we can use assessments from the ecological framework to help address health disparities in um, African American clients or patients. It also talks about identity issues and how they impact mental health. The week's reading also gives you a good idea of what are some of the social, cultural implications of being African American and how that may impact mental health as well as physical health. And it gives a good example of that. As stated, we talked about dysfunction and stressors as part of abnormalities and how we measure and observe abnormality. The week's reading in your health and your handbook of African American health also talks about some of the stressors and the stressor model that African Americans deal with as well. And it provides a very good diagram of what that stressor model looks like. And so that this chapter's reading really gives you, it pulls together some of the concepts that we've been talking about in understanding abnormality, um, what things to think about when you're thinking about DSM-5 diagnosis and critique, as well as social, cultural, political factors on a particular and specific population. So hopefully you did that reading and it helped bring together a lot of the concepts that we talked about in this week's chapters. Thank you.